Hello again, everybody. Welcome back to part 4 of our online lecture series on musculoskeletal conditions. So in this section, we're going to be looking at musculoskeletal trauma, in particular pathophysiology, the clinical manifestations, and also complications. So what I've tried to do, so you will recall from the subject outline that this subject's all about linking the underlying pathophysiology to the clinical manifestations that we see when we do our assessments, and also linking the clinical manifestations to our the pathophysiology to our nursing intervention. So what I've tried to do in this slide, with these slides, is to show you what we mean about linking those things together and how they relate, and hopefully this will help a little bit with your assignment. So the first thing that happens when a fracture occurs is that excessive force disrupts the continuity of bone. So that's where we talked about the deformity that we talk about or that we see when we talk about assessment comes in, and also crepitus, which we talked about in the earlier lecture on assessment, which is that grating sound that we hear or that we can actually feel when you palpate the particular area, and also loss of function. So they're three clinical manifestations of a fracture, and the cause of that is that excessive force that disrupts the normal continuity and the normal alignment of the bone. So what then happens is that muscles start attempting to try and keep the ends of the bones in alignment, and that can result in muscle spasms, which are painful, and also which lead to significant pain as well. So we talked about the periosteum, which lines the outside, or is a membrane that lines the outside of the bone, and that contains blood vessels and also nerves. So damage to the periosteum stimulates nociceptors, which then send messages to the brain, and that results in the person experiencing pain. Disruption of the blood vessels in the periosteum, which is attached to the ends of bone and around the bone, cause bleeding. It also causes some of the bruising that we see in a particular fracture, and also leads to swelling as well. So you'll remember when we talked about bleeding and hypovolemic shock back in module 2, we can have relative hypovolemia or absolute hypovolemia. So we can have an outward hemorrhage, which we can see and measure, but we can also have bleeding and fluid loss occurring within the tissues, that the blood doesn't actually leave the body, but it has left the circulating blood volume, and therefore will have consequences for the person. So that's where a lot of the bleeding, bruising and swelling comes from, is that damage to the blood vessels in the periosteum. The other thing that happens to a certain extent, with some fractures more than others, is that we have damage to the surrounding tissue. So when we talked about comminuted fractures in the previous online lecture, you can see that with a fracture like that, there can be significant damage to surrounding tissue. That can include damage to blood vessels, so that can further increase bleeding. That also results in swelling, and it also results in some of the pain that's associated with a fracture as well. So the bleeding and pain that we see associated with a fracture stimulates the sympathetic nervous system, and we've talked about that a bit when we talked about shock and hypovolemic shock in module 2. So when the sympathetic nervous system is activated in response to a reduction in circulating blood volume, and also in response to pain, adrenaline and noradrenaline are released, and that acts on the beta receptors in the heart, which results in increased heart rate. Also acts on respiratory rate, so we see tachypnea or increased respiratory rate, and hypotension as well. Just a little aside and a little tip with your assignment too. You can see there that I'm using medical terminology or nursing terminology when I say tachycardia instead of rapid heart rate. I'm saying tachypnea instead of breathing fast, and I'm saying hypotension instead of low blood pressure. So we want you to get used to, particularly in your assignment, your written assignment, to get used to actually using those correct terms as well. So when we see someone with a fracture, you will likely see that their heart rate will be elevated, they'll be breathing more quickly than usual, they might be a bit hypotensive, and all that relates to the either loss of blood volume and or some of the pain that they might be experiencing. So with any type of injury, we also have an inflammatory response that is activated. and that's caused by the acute injury to the surrounding tissue and also to the death of any bone tissue around the fracture site. So that causes vasodilation and increased blood flow to the area. That contributes to our swelling. So if we go back and look at the symptom of swelling, we've got a number, or clinical manifestation of swelling, we've got a number of things that are happening to contribute to that. We've got active bleeding from the site due to damage to the periosteum, the blood vessels in the periosteum. We've got bleeding and damage to the surrounding tissue, and now we've got this inflammatory response that's happening. So the blood vessels in the area dilate to get more blood into the area, with the idea of bringing in, white blood cells for phagocytosis and those sorts of things. And that causes increased swelling as well, and that can increase the pain that the person experiences as well. And edema and bleeding, or swelling and bleeding, also puts pressure on the surrounding nerves and blood vessels as well, and that can result in paresthesia, which we've talked about, which is the loss of feeling or tingling, pallor due to lack of blood flow to the area, paralysis, pain, and lost or diminished pulses as well, but we'll talk about those in a little while as well. So just quickly, because bone healing has an impact on the clinical manifestations that we see as well. So usually a hematoma or a big blood clot forms over the site of the injury within about 72 hours of injury. So you can see here, soon after the fracture occurs, we've got macrophages and inflammatory leukocytes moved into the damaged area to scavenge debris and begin producing pro-inflammatory agents that start to initiate healing. So within about 3 to 14 days, we have granulation tissue and asteroid formation, about, as I said, 3 to 14 days after the injury. So the inflammation triggers cell division and growth of new blood vessels, chondrocytes that secrete collagen and create a fibrocartilage that forms a soft callus. So that soft callus is usually started to form by sort of about the end of the second week after the fracture. Then over time we have ossification occurring within about 3 weeks to 6 months, and that causes a hard callus to form. And that's when bone starts replacing the soft callus to create a hard callus around the broken ends of the bone. And then we have remodeling. So remodeling can take up to 12 months to occur. So that's where stronger, more organized bone starts replacing the weaker bone that's formed the hard callus. And because it's continuously remodeled, the bone is the only tissue that can heal without an obvious scar. So any interference in that bone healing process can result in complications, and we'll talk about those as we move through. So talking about some of the more dangerous complications of fracture first. So the first one is hypovolemic shock. So as I just mentioned earlier, it is possible to lose blood from a fracture and bleed internally from a fracture. And as I said, that's from damage to the blood vessels in the periosteum itself, and also damage to surrounding blood vessels by the broken ends of the bone. And also because when this inflammatory process occurs, the capillary permeability increases to let all those white blood cells and leukocytes and inflammatory mediators into the site. So you end up with a loss of extracellular fluid or intracellular fluid into the damaged tissues as well. So hypovolemic shock or hypovolemia and bleeding is more common in fractures of the long bones, such as obviously the femur. It's possible to lose up to a litre of blood from a fractured femur, and fractures of the pelvis can be quite dangerous as well and can result in significant blood loss. So just because you can't see visible bleeding doesn't mean that it's not. The second quite dangerous complication of a fracture is fat embolism syndrome, or FES. So it occurs more commonly in fractures of the long bones pelvis, in people with multiple fractures and other trauma, and in people with crush injuries. So what happens, and this is a theory only because the actual mechanism of fat embolus is not well understood, but understanding is increasing over time. So what the current thinking is that there's increased pressure within the bone marrow caused by a fracture, and when the pressure in the bone marrow exceeds capillary pressure, fat globules or little lumps of fat are released into the bloodstream and enter the circulation. So once released, they combine with platelets, and remember, platelets, when they're activated, become sticky, and they form little clumps or platelet plugs. So once the fat embolus is out and about, it can travel to the brain, and if it travels to the brain and blocks an artery, it causes an ischemic stroke. It can travel to the lungs, where it can cause a pulmonary embolus, or it can travel to the kidneys. And because they're small, it can actually be lots of them, and that can cause damage or occlusion of all the little blood vessels that supply the tissue, and that can then result in tissue ischemia. And if tissue ischemia goes on for too long, then that results in cell death. So it's quite a severe and significant complication. So altered cerebral blood flow can result in neurological compromise. Disruption to pulmonary blood flow and damage to the alveolar capillary membrane by these little fat globules can cause pulmonary edema, atelectasis, which is collapse of the alveoli or functioning units of the lung, and it can lead to quite severe respiratory failure. So I actually had on my I think it was my second day working in ICU, I had an experience with fat embolism syndrome, and we were looking after a patient who was the race weekend, the Bathurst race weekend, I should say, the car races, and he had fallen off. He was only a young guy, fallen off a grandstand up the mount at Mount Panorama, and he had broken his femur. So he was in hospital, he was on the surgical ward, and we actually got called, or he came down to ICU after having had a respiratory arrest. And that was caused by the pulmonary complications associated with fat embolism syndrome. So the other thing that the fat droplets do is that because they're foreign and they're floating around in the blood, they activate the clotting cascade, and that can result in thrombocytopenia or a lack of platelets. Microvascular clotting, so all the little tiny clots that occur, can cause a petechial rash. So a petechial rash is sort of pinky purpley, looks like little pin pricks on the skin. Prompt stabilization of long bone fractures is important because it actually prevents fat embolism syndrome from occurring. So some of the other symptoms that you may see, and the symptoms can occur, or manifestations can occur within a few hours but up to a week. So in the patient I was just telling you about, it was the next day. So you might see, if it's affecting the brain, personality changes, restlessness, agitation, confusion. So if you've got someone who's had a fracture or had a trauma and they start getting agitated or confused, that's a red flag that there might be something going on. Respiratory will be increased respiratory rate, crackles and wheezes on listening to the chest, pain with inspiration and a cough, and in severe cases respiratory failure, which you'll see as decreased oxygen saturations, and those sorts of things. So what really can only really be done for these patients is supporting them through this particular complication. So respiratory support, so I've seen people end up on mechanical ventilation for a period of time with fat embolism syndrome, managing fluid and electrolytes, replacing platelets and other blood products that are getting used up because of the clotting process, and just basically supportive management to get the person through that difficult period. So anyone with fractured long bones, fractured pelvis, multiple fractures, you need to be very, very much on the lookout for this fat embolism syndrome. The other thing you need to be on the lookout for is compartment syndrome, and this is another very serious complication because it's limb threatening. So if someone has compartment syndrome in a limb, they can lose that limb if it's not managed properly. So basically you can see in the picture here that a compartment is a space enclosed by bone or fascia. So in this case we've got the tibia here, and then we've got these little compartments. So there's the anterior compartment, the lateral compartment, there's the fibula, and then we've got superficial posteriors. So what happens is that you've got fascia, which is a thin sort of layer of connective tissue that surrounds all of these little compartments. So say if we choose this superficial posterior compartment here, if we get swelling in here or in any other of the compartments, there is nowhere for it to go. And these compartments also contain muscles, blood vessels and nerves. So the body has about 46 different compartments, and 36 of them are in the extremities. So it is possible to get abdominal compartment syndrome as well, but we're mainly talking about compartment syndrome in the extremities because of a fracture. So loss of function can be permanent after 4 hours, because what happens is that an increase in pressure in a muscle compartment causes a severe decrease in blood flow to the extremity distal or on the other side of the injury. So that can cause damage to the nerves, and it can also cause damage to blood vessels and block blood vessels, so that oxygenated blood is no longer getting to the distal part of that limb. So loss of function can actually be permanent after 4 hours of ischemia. So it's really important that this is picked up very quickly and that it is managed to prevent the problem from occurring. So if the pressure is not relieved and blood flow is not restored, then you'll end up with ischemic necrosis or death of that tissue. So with compartment syndrome, it can come from one or two places. It can come from the swelling in the limb itself, and or from a cast that's too tight. So you can imagine if you've got swelling in the limb itself and a cast that's too tight, then that's going to be double the problem. But sometimes it can just come from the cast being too tight on its own. So because the implications of compartment syndrome can be so dire, it's really important that we're able to spot it easily. So that's the reason after any sort of musculoskeletal trauma or injury and after any musculoskeletal surgery that we do our neurovascular observations regularly on the affected limb. So the things we're looking for in compartment syndrome are the 5 Ps: pain, which we'll talk about in a minute, paralysis or lack of ability to use or move the limb, pallor, paresthesia, which is that tingling or loss of sensation, and loss of pulses as well. So pain, paralysis, pallor, paresthesia, and pulselessness. So the pain associated with compartment syndrome is quite distinctive. So it's a very deep, throbbing and severe pain that continues to get worse despite the administration of opioid analgesia. So for example, you have a patient come back from theatre post-op after having, something done with their femur, for example, and they complain of some pain. You give them the morphine, they come back, you reassess, they say no, the pain's still getting worse, and it continues to get worse. The patient becomes more and more distressed with the pain because it's very severe pain, and that's an indication, along with the other 4 Ps, that compartment syndrome may be occurring. So just remember that that's the pain that gets progressively worse. It's unrelenting, and opioid analgesia does not fix it. So in terms of management, if the person's got a cast on, then we need to get it off. Or any type of restrictive tight dressing or clothing or anything like that, that needs to come off. We don't elevate the limb, because if we elevate the limb, what we're doing is actually making the heart have to work harder to get oxygen to that limb. And that's then going to decrease the oxygen supply to that limb even further. So we maintain the extremity at heart level. If all else fails, and once again, I'm sorry about the yucky picture, but the patient will need to go to theatre, or if time's not available, have it done there and there on the spot. And the procedure that's done by preferably a surgeon is a fasciotomy, where they actually make an incision, and you can see the sort of fascia overlaying some of the muscle there. They make an incision to actually let the pressure out, basically, and so that wound will be left open for a period of time until the pressures in that limb drop and you get an improvement in the neurovascular observations. So in addition to those sort of really significant complications, there are others. One of them is deep vein thrombosis. So deep vein thrombosis is a blood clot that forms in the internal lining of a large vein, and they can dislodge and travel to the lungs and become a pulmonary embolus. So you'll talk about DVT in different topics and different subjects, but immobility, and which causes venous stasis, is a big concern with or a risk factor for the formation of a DVT. So that's one of the reasons why we're keen to get people up and moving as quickly as possible. Infection is obviously a problem in an open fracture, because once that wound's been opened, there's a risk that there's been pathogens and things that have got access to that wound and microbes. So any reduction in blood supply can also increase the risk of infection. And once we get osteomyelitis or an infection in the bone, it's very, very difficult to treat, and it will result in delayed healing. So we need to be very, very careful with infection. The other thing there is delayed union, which results in prolonged healing. So delayed union can be seen in someone who has poor nutrition. So one of our overall things we need to be looking at when we're looking after people with musculoskeletal trauma and injuries is their nutritional status. Not getting them up and mobilising as quickly as we can. If infection occurs in the bone, that can cause a problem. Age, so wound healing or fracture healing is more difficult as we get older, as is everything. Immunosuppression, all of those things can lead to non-union or delayed union, and then sometimes non-union can occur. So if that happens, there may need to be further intervention and surgery done. My little brother broke his leg a few years back, actually, the three of us, we've all broken our legs at some point. But my little brother broke his leg a few years back, and he was just playing soccer, and he rolled it on top of the soccer ball and twisted it. And I'm pretty sure he had a spiral fracture as well. And I was actually visiting when he just had his closed reduction done on that, and he was still getting quite a lot of pain. And usually after the fracture's been reduced and the cast has gone on, the pain does settle. So he was still getting a lot of pain, so he went back to the fracture clinic a few days later, and they found that they weren't happy when they did an x-ray with the alignment, and that's why he was still getting so much pain. So they had to take him back to theatre, take the cast off, reduce it, and then put the cast back on, and after that he was perfectly fine. So with the complications, please keep those three nasty ones in mind, so fat embolism, hypovolemia, and compartment syndrome, but we also have to be aware of infection in particular as well. So that covers the complications and the pathophysiology of fracture. We'll move on next to have a look at some of the surgical and other interventions that are used in the management of someone with musculoskeletal trauma.